How do you think about aspirin? Somebody taking that preventatively if they haven't had an event in the past, and then somebody who has had some kind of heart attack, stroke, stent put in, using that as a long-term strategy.
The job of aspirin is to prevent platelets, which are the little sticky molecules in our blood that start a blood clot process. Aspirin inhibits the platelets from sticking together. There are other antiplatelet medications. Plavix is probably the other one that's most commonly used. It's also clopidogrel is the generic name. There are like Brilinta. There's a few of them. If you have had a heart attack, a stroke, or a stent put in, you are on some kind of antiplatelet medication, and the best evidence we have suggests that you should stay on that, some version of it, whether it's aspirin or Plavix or something. Whatever your doctor puts you on, if you have had that event, that stent, a reconstruction of your blood vessels anywhere, please stay on your antiplatelet drugs. That is important for you, irrespective of your age. If you have not had any events and we don't know if you have any plaque and you are just thinking that an aspirin a day keeps the doctor away, you probably should not be taking aspirin. The most recent evidence that we have for primary prevention does not really support the use of aspirin in the broader population just to prevent an event. And that's especially true the older you get, because aspirin, even though most of us think of it as a reasonably safe drug, or it's over the counter, it's not that dangerous. However, again, at a population level, it's associated with increased bleeding complications, and those increase as patients get older. So over 70, primary prevention, bad idea. Even over 60, primary prevention, not great. Under 60, if you have a couple of specific conditions, we would talk about it. So let's say you're under 60, you're a 50-year-old person who got a coronary calcium score because you listened to this conversation with Jesse and you're like, oh, I should check out my blood vessels. Got a calcium score and it was 400. But you've not had a heart attack, you've not had a stroke, you don't get any chest pain when you exercise. Aspirin for you might be worthwhile, right? Risks might be less than the benefits for you. That's a gray zone. And Lp(a) is another gray zone. There are some people with Lp(a) who get disproportionately better with aspirin therapy. It has to do with one particular mutation in the Lp(a) gene. But in some series, people who have elevated Lp(a) who take an aspirin have an outsized benefit from that particular intervention. Now, again, we're going to weigh the risks of bleeding. We're going to talk about your age. We're going to talk about how likely are you to have this event? What else is going on in your health? But I would say elevated CAC or elevated plaque imaging of any kind and Lp(a) would be those gray zone areas for people taking aspirin.
Can you talk more about the mechanism, what it does in the body, physiology-wise? And then for somebody who wants to do it in a natural way, any supplements out there that work in a similar way?
The plaque rupture that we talked about, right? The eruption of this volcano in your arteries where you have this soft, lipid-rich magma, molten lava situation. When that ruptures, all of that inflammatory stuff shows up inside your artery all of a sudden, and the body's like, whoa, 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 this is toxic. We cannot have this. We need to fix this. The way that starts are the platelets. The inflammatory component of that lava that's just erupted immediately attracts these platelets, and these platelets are just going to cover all of that goo and stuff, and the platelet forms this clot, and it's the clot that blocks the blood flow and causes the heart attack and stroke, but it's your body trying to contain this eruption, and the platelets sticking to it is the first step in this whole process. So if you make the platelets less sticky, then you get less of a reaction to all of that, and you are less likely to completely block off the vessel if this happens. And again, there are other medicines that also inhibit platelets that can do this, but aspirin is how it works. It just reduces the stickiness of those platelets to form. So you're less likely to get this complete blockage in a plaque rupture situation. And the platelets are permanently inhibited. So the lifespan of a platelet is 7 to 10 days. So if you take an aspirin every day, then your platelets are always inhibited. If you take it every other day, you're getting some inhibition, but you're getting some new platelets that are not yet inhibited. And so there's less of an effect. There is no supplement or like intervention that is a medically appropriate substitute for aspirin or an antiplatelet. So if you have a stent, if you have had a bypass of some kind, and somebody's like, hey, you should take some nattokinase instead of your Plavix, I'm going to tell you that's a bad idea. Now, nattokinase is probably the one that comes up the most often in this context, and nattokinase has a small amount of antiplatelet activity. It also has some antifibrinolytic properties, or some profibrinolytic properties. So fibrinolysis is the process of breaking down clot that has already formed. So our body has this beautiful, very complex pathway where we make clot, but we also break it down because we know that we don't want to bleed to death, but we also don't want to block off every pathway in our body for blood flow. So the body has this beautiful like ebb and flow of like making clot and then breaking it down. So fibrinolysis is the breakdown of clot that's already formed. The LPA molecule we talked about earlier is partly impacting this clot breakdown side of the equation. Nattokinase is favorably going to potentially help break down clots. Nattokinase is a very interesting molecule, right? It's derived from the fermented soy product natto. We know that people in Japan who eat a lot of natto tend to have lower risks of heart disease and stroke than people who don't. That doesn't necessarily mean that nattokinase as a isolated enzyme is going to help. We don't know how much nattokinase gets absorbed. The data for nattokinase are actually best for blood pressure, and like why it impacts blood pressure preferentially is a little interesting. There have been some studies that show that it reduces lipids, others that show that it increases lipids. There is one study that was not randomized, was not placebo-controlled, that showed plaque reduction using high doses of nattokinase. There have also been a couple of case reports that showed bleeding events associated with nattokinase related to this. So while it's an option and it's an interesting molecule, I actually tried it in a couple of patients. I had one patient who took it for a year. We repeated her CIMT and it went up, which is not good, more than would be expected just based on age. And we quit because I didn't think it was helpful and it was potentially harmful. So I was really excited about it when I first read this study that showed plaque regression. As I have reread the study and thought about it more, it's not a particularly strong study in a lot of ways. And it's the only one. There's been a randomized controlled trial that showed no change in CIMT at a much lower dose, acknowledging that. But, we don't know yet. I would say that it's possible that someday we will be using nattokinase, whether we're doing it because it has anti-inflammatory properties, anti-clotting properties, whether we're doing it for lipid properties or blood pressure. Like, we don't know why it's working. And there have been people that have tried taking nattokinase instead of their blood thinners. Somebody clotted off their brand new heart valve doing that. So I would be very, very careful using nattokinase without the blessing of your clinical team. And if you are on a blood thinner for a blood clot, if you're on an antiplatelet for a stent, please don't stop any of that before you talk to your clinician. And please don't take nattokinase on top of that because there are also some case reports of bleeding issues. So it's interesting. I am open to patients using it. Like, we just have to be very thoughtful about it.
Somebody young, healthy, no plaque, no heart events. Can you see any value in using that low dose preventatively to prevent plaque?
We don't know. We just don't know. I mean, the randomized controlled trial would say no. Does that mean the dose was wrong? We're not sure, right? I would say, in my younger patients, what I want is a clear understanding of what their pathway to plaque would be. Are we having problems with overweight and in visceral fat and causing inflammation? Are we having issues with toxic exposures like tobacco, nicotine, even cannabis, if it's smoked, can cause cardiac issues? Are we having issues with blood sugar and hyperinsulinemia? Like, what is the thing that's going to really reduce our risk for that patient? Because I feel much better that if I have a tangible pathway to plaque, then that is something I can intervene on. If it's high blood pressure, then there may be some role for lower dose nattokinase for that. The blood pressure data for nattokinase are actually okay. And that would be something to think about if for whatever reason somebody would prefer to do that than other mechanisms to lower blood pressure. Sure, we can talk about that.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
I, as a vascular surgeon, predominantly see people who've had a problem already from plaque. Why do you have plaque? Is this an inflammation problem? Is this a lipid problem, an insulin problem? Where is this?